Hi, my name is Casey Glass, and I'm the Ultrasound Director for the Center for Experiential and Applied Learning at Wake Forest School of Medicine. And this is an introductory lecture on ultrasound-guided procedures. It is required to move on to the other specific ultrasound-guided procedure modules. And in this talk, we'll be discussing the use of ultrasound as a patient safety tool and go over some of the basics of ultrasound-guided procedures, including the idea of in-plane and out-of-plane needle guidance. So, before ultrasound became widely available in small compact machines, most bedside procedures were done based on surface anatomy. And as patients deviated from a standard ideal patient, their procedures became more difficult to complete. And when ultrasound became available at the bedside, pretty quickly we realized that it facilitated these procedures and allowed us to complete them faster and with fewer complications. The real change was in the late 90s to early 2000s when ultrasound really became commonplace for placing central lines at the bedside. And since then, bedside ultrasound has extended to help facilitate many other procedures, including paracentesis, thoracentesis, peripheral IVs, essentially all procedures for which the anatomy is easily visible on ultrasound. The fundamental principle of ultrasound-guided procedures is that we need to be able to keep the ultrasound image and the needle tip visible at all times. The core principle of ultrasound-guided procedure is that we should always know where the needle tip is at all times. So there should never be a point during the procedure where the needle tip location is unknown. When we're talking about ultrasound-guided procedures, there's really two different ways that we can move the needle through the ultrasound beam while we're doing the procedure. One method is called the in-plane approach, and in an in-plane approach, the ultrasound beam is always over the needle. The operator brings the needle in from one edge of the ultrasound probe and takes the needle under the probe towards the other edge of the probe. So again, the needle is in the ultrasound beam the entire time. The other approach is the out-of-plane approach, and in that approach, the ultrasound beam and the needle are sometimes in different places. So usually the needle starts into the tissue a little bit away from the ultrasound probe, and the operator drives the needle towards the ultrasound beam so that the needle tip will enter the beam near the target. So here's an example of an in-plane image. So the needle is coming in from the left side of the probe, and it is going underneath it towards the right side as we face the probe. And in the image, it comes in from the left side of the image, and it's moving towards the right side of the image. The needle itself is visible as this white echogenic line that ends in a brighter flare of the needle tip. The in-plane approach has the advantage of showing us the needle the whole time. Once the needle is under the ultrasound probe, we'll be able to see it in the image all the time, and the needle tip and needle won't ever wander into tissues that we're not looking at. It can be a little bit harder to guide it into the target because if we take the needle and wander sideways out from under the ultrasound beam, we won't be able to see the needle at all, and it can be a little harder to bring it back in towards the ultrasound beam. Also, if the thing we're trying to stick is small, the probe can drift away from it on the surface of the skin, and the beam will be looking down at some other tissue. And so it takes some practice to keep the ultrasound probe lined up over our target and not let it wander across the patient's skin as we're trying to move the needle in underneath it. Lastly, there needs to be enough space on top of the patient to fit the probe the long way to do this procedure. And sometimes if we're working in a tight spot, there's just not enough room to fit the probe the long way. This is an example image of an out-of-plane image. So in the out-of-plane approach, our target usually is seen in cross-section, so a blood vessel looks round like a coin instead of long like a tube. And then the ultrasound needle starts out of the image. So if you, the viewer, are looking at this, you can imagine the needle starting out in space near where your head is as you watch the image, and then moving towards the screen that you're looking at until it intersects with the ultrasound beam in the image. And in this particular picture is that little white dot in the middle of the vessel. And then the needle will continue through the screen into whatever is behind your phone or laptop or tablet or whatever you're watching on. And so you can understand how the needle travels through tissues that are not part of the picture we're looking at before we see it in the ultrasound picture. Now, although there is certainly big downsides to the fact that the needle is going through tissues that we're not looking at, the out-of-plane approach does have some advantages. For one, it's a lot easier to see the things around the target. So if we miss the target, it's easier to send the needle in the other downsides really are that because the needle travels through things we're not looking at, it's easier to go through the back of the blood vessel. It's easier to stick other things around our target, and it can be somewhat more difficult to find the needle tip if we're going to kind of follow it more carefully towards the target. And so it's important to keep in mind, and this would be important to remember, that the in-plane approach overall is associated with less complications, especially when we're using it for vascular access. And it is the standard approach for most procedures where the probe will fit in the space that you need to use the in-plane approach. The out-of-plane approach, although it has some drawbacks, overall is easier for beginners to learn. And personally, I found it to be much more successful when the target is small. So small targets are hard to keep underneath the ultrasound probe in the in-plane approach. Now, when we're setting our machine and image up to do an ultrasound guided procedure, it's important to understand how we'll be able to determine how far into the patient's tissue to go with the needle. To do that, we need to know how to read the depth information off the ultrasound image. So in this particular image, the depth is this 1.5 that shows at the bottom right hand of the ultrasound picture. Also, all machines will have some sort of a graduated scale along the edge of the image to give you depth information. On this machine, it's a little bit harder to see, but there are little dots along the right side of the ultrasound picture that start at the top of the ultrasound image itself and then come down towards the 1.5. And so if you combine that with knowing the total depth is 1.5 centimeters, we know that the brightest dot is a whole centimeter and the smaller dot is a half a centimeter. When we're preparing the image to do the procedure, we want to try to fill the screen with our target and have enough tissue imaged around there so that we can keep an eye on where we're going. So we don't want the thing we're targeting to be very small and at the top of the image. We also don't want it to be right at the bottom of the image. We want to try to get it as much to the middle of the image and as big as we can make it appear in the image. It's important to be careful about how we set the brightness of the image. Again, the gain control affects how bright the image appears as we're looking at it. Blood vessels, which are mostly water, should be black or anechoic in the image, and to make them dark, we would turn the gain down. The tissue around them should be relatively bright, and so if that tissue is too dark, we would turn the gain up. And so that we'll have a nice contrast, which will help our needle to pop out of the image and make it easier for us to see. When the needle is in the image, it will appear bright or hyperechoic. The brightest part of the needle is the tip where the bevel is, because the bevel reflects a lot of the ultrasound beams back to the probe. The shaft will be bright and hyperechoic, but it will be less so than the tip, and it can blend in with other tissues if you're not careful. In the top left image, we have an in-plane view of the needle, and in the bottom left image, we have an out-of-plane view of what is probably the needle tip, that bright white dot right in the middle of our target vessel. Needle tips can be hard to find, especially in actual human tissue, where we're looking right here at an image of a phantom, and you can see there are lots of other hyperechoic or bright white dots over the blood vessel. It would take a little bit of searching to make sure which of those was our actual needle tip if we were performing the procedure. If we need to find the needle tip in a setting like that, there's a couple of things that you can do. You can gently bounce the needle tip, knowing that as you bounce it, you will be potentially disrupting the tissue near the needle tip, so we need to be very careful about that. But that needle tip bouncing will move the tissue near the needle tip and help you identify where it's at. It's also helpful sometimes to move a little bit more slowly. So in this case, the needle is advancing and the operator is bringing the ultrasound probe back towards the needle tip to help find it before they continue on into the tissue. So you can see the needle tip appearing there is a little white dot above the blood vessel. All right, we've discussed how to identify the needle tip in the image, how to set our picture up. When it goes to actually holding the probe, we want to generally keep the probe in a standard orientation. So if we're doing an out-of-plane approach, most of the time we should have the index mark, the part on the probe that lets us know which side is which. That marking should be towards the left of the operator or the person doing the procedure. And that will mean that in the image we're looking at, things that appear to be to the left of our target actually are that way, and things that look like they're on the right of the target really are that way. If we were to flip the probe 180 degrees, our directions would be backwards and we'd start sending the needle in the wrong direction. For the in-plane view, typically we would keep the index mark on the probe, the mark that lets us know which side of the probe is which, we would keep that towards the operator. There are some procedures and some specialties where they reverse that and prefer to keep the index mark away from the operator so that the needle enters the image from the other side of the image. And so if there's a difference, we'll make sure we note that as we go through our procedure modules. So again, this is an out-of-plane cannulation, so the operator is kind of slowly moving the probe forward, always keeping the needle tip in view till they reach this target vessel. And then here is an in-plane long axis view. Again, the needle is always underneath the image and the needle is advancing into this blood vessel, and you can see the cannula actually being pushed off there into the lumen of the vessel. So to sum it up briefly, it's important to know there are two different methods for guiding the needle during ultrasound guided procedures, in-plane and out-of-plane. Overall, in-plane guidance is associated with fewer complications because we can be sure that we'll see the needle through the whole tissue path of the needle. It's important also to keep in mind that we need to set the machine gain and depth settings appropriately to get a nice contrasty image where our needle is going to be as visible as we can make it for our procedure. That's it for the Intro to Ultrasound Guided Procedures lecture. Please go ahead and take your quiz and you'll be ready to go on to the other ultrasound guided procedure modules. Thanks.